Next up is Dr. Aditya. He's going to speak to us about capsular Rhexis in complex situations.
Good afternoon, everybody. I'll be talking about perfecting capsular Rhexis and difficult situations. I think this is a very, very important step of the cataract surgery, and one which can actually save you millions, because you don't need to invest in different machines now that are available if you can perfect your capsular Rhexis the way you want and how you want it. So the recommended CCC is about round and well centered. Size should be around 5 to 5.5 millimeters, and it should overlap the IOL optic approximately 0.5 millimeters symmetrically, 360 degrees, and consistent effective lens position, which is very important in your calculations nowadays, should be met. Otherwise you will have a refractive surprise. And you saw in Dr. Reena's video how beautifully she did make her capsular size the way she wanted to in her last case. So a few tips before I begin to the difficult situations is choosing the right case. When you're starting off choose the right case, use your correct anesthesia, and choose your favorite technique of doing it. My favorite is the capsular Rhexis forceps, and you can see how I do that. So another thing is, whenever you're injecting your viscoelastic, always do not remember, you don't need spaghetti, you need to coat it. So a lot of us just spray the viscoelastic like a spaghetti or a noodle, and that's not what we desire. And a good control, like sir suggested, you can use a high density viscoelastic also, especially in pediatric or cataracts where you expect a run out, you can use them. And pinch, grasp, take it around, and then once you have a nice flap, re-grasp, and then continue your shearing and tearing forceps till you finish the Rhexis in one go. That would be the preferred way of doing it. Often you may re-enter, and if you do, inject OVD, fill the bag again, and then again re-grasp near the intersection. So how do you manage difficult situations? So one first difficult situation is when it extends. How do you manage those? First thing, you need to know, why does the Rhexis extend? It will extend if you don't have a good visualization and you go and take a nick and you don't know where it's going and you keep pulling. It could be because of capsular elasticity or pseudoelasticity that is in that patient, a shallow anterior chamber, or a sudden moving eye and your burping of visco happens, or if there's a tendency already. So in this case, you can see I started with a cystotome. And as I'm continuing my Rhexis, somewhere in between you can see there's an extension which is going to happen. So I switch to my forceps, fill with OVD, and then try to pull again and again. And there's a point where I realized if I pull it's just extended too much, so I took a nick and continued my Rhexis thereafter. So this is one of the ways you can manage a good Rhexis without panicking. If you can make a judged decision and not continue, it may be a good idea. You can do this. You can also take a nick on the other side and continue from the other side. So the first nick is very important. We all know that. If you make a bigger nick or go more to the periphery, you'll have a problem. Grasp close to the tearing point. Grasp and re-grasp is very important. And whenever it's spiraling outwards, detect that first. Don't let it spiral all the way out. Another case where there was a little extension. If you can notice, the first incision took it so far off that I had to switch. Now you know why my favorite technique is the forceps. So I decided to go into via the forceps method. And then grasp near the tearing point and pull it inwards. This is the Little's technique, where you flatten it and pull it towards the center, like in a pediatric cataract you would. And then you make a nice heart-shaped Rhexis. Another case where you initiate with a cystotome, continue, and then somewhere down the line we realized there was an extension. Right there. So if you fill the bag again and do the Little's technique with the cystotome also, it's possible, and you can get your Rhexis back and complete your Rhexis. So those of you we are comfortable with cystotome, you can go ahead and do the little technique with this as well. Some special situations which can often be perceived as very difficult situations are zonal weakness, hypermaturity, use of hooks like we just discussed, aims for smaller Rhexis. So like in this case, it's a hypermature cataract. You know it, when the moment you take a nick, something is going to go wrong. So you can just take a nick and drain a bit of the liquefied cortex so that you don't have a lot of tension there and there's no run out. Once you're done with the draining, it proceeds like a regular capsular Rhexis. But here also, always be cautious that you don't let it run too far. A lot of things have been advocated for hypermature and intumescent cataracts, like making a small Rhexis, use of forceps. I think all of them are good techniques to follow. So you decide which technique works for you the best. So as you can see, there's going to be a run out here. Expecting that, being a little more eager, I decided to make a Rhexis from the other side. I'll just forward this a bit. So in the end, a decent Rhexis which I could complete by making another nick and continuing. So in traumatic pediatric, being a pediatric ophthalmologist, I had to show a pediatric case as well. So this is a good case where there was a half and half Rhexis done. So after staining, you notice that there's already anterior capsular tear and there is a fibrosis with the adhesion right there, and it's difficult to release that adhesion. So the best way I could think of doing a Rhexis here is raising a flap using my forceps, completing half of a Rhexis on one side. And once I completed that half Rhexis, I went to the other half. And completed that half as well. So give me a nice Rhexis in the end. So when there are weak zonules, sometimes it's very easy, sometimes very difficult to get the Rhexis right. Like in this case, there was a sort of run out that you can see is happening. So used the Little's technique and completed my Rhexis without putting too much pressure on the zonules. So forceps is generally the best method in these weak zonular cases. So in summary, creating an intact Rhexis is critical for a safe procedure and maximize success. You must know your enemy potential, read about it, then be ready with your backup plans and go ahead and do it. Thank you.
Very nice, Dr. Aditya. Aditya, tell me, if you have an anterior capsular fibrosis right in the center, okay, so how are you going to manage that?
So generally take a nick a little beyond it and then go around the fibrosis and take it in your Rhexis flap rather than try to pull through it. If the fibrosis is too big, you can even try peeling the fibrosis. And if it's very big, then I think Zeptos and all also work wonders on it. Otherwise, you peel it one by one. I think Dr. Deepak Megur had showed a beautiful video where he would peel
double-handed. You need to actually use your venas. So basically what you can do is you can use the cystotome wherever you see that the area is clear and the fibrotic plaque is not there. And then with one instrument you have to lift the capsule, and the other hand you have to cut it, nick it, or cut it around wherever you can, and in the clearer area you can pull it around. So basically a mix and match of different techniques. Anything else?
Yeah, and another thing is that modern micro surgical instruments have made things very easy. That means you can go through the side port. You have a capsular Rhexis forceps which can go through the side port. The chamber is formed. You're not through the main port. You're not losing viscoelastic, especially if there's an intumescent cataract. If there's a wide cataract where the intralenticular pressure is pushing the capsule outwards. So making a small Rhexis and making a nick and making a bigger Rhexis in a two-step capsular Rhexis is also a fantastic way of, a very safe way of handling the capsular Rhexis in a intumescent wide. Another important issue is that immediately as the Rhexis, whatever the reason, whether we started off big or whether there are other factors, once it starts going out, a sense of stress and panic sets in. So at that time we need to just cool down, think about it again and restart, and most of the times you're able to make it.
I think you need to tame your Rhexis. So even if it's running wild, whenever you leave and you come out of the chamber, always leave it like a flap. You know, the Rhexis like a flap. If you leave it like that, it will never go out. But what happens is that we just see that it's going out and we just come out. But that's what one thing which you're not supposed to do. Just leave it turned like a flap and then come out. So then you will never have a runaway.
Also, how many people over here have never used a capsular Rhexis forceps and are completely comfortable with the cystitome? Okay.
That's partly because I use an AC maintainer in all my cases. So,
no turbulence.
The forcep doesn't go with the AC maintainer. So I have got used to using a cystitome all the time.
So then are intumescent cataracts also good in your hands with just using a cystitome?
Because the milky fluid keeps on getting washed
Yeah.
With the AC maintainer.
getting a clear
With the
with the
AC.
AC maintainer.
Correct.
Wonderful.
The pressure is maintained.
So I had the pleasure of witnessing Dr. Professor Blumenthal, and I assisted him in about, I think, 12 or 14 surgeries, where he picked up only intumescent and hypermature cataracts, and it was like a cakewalk. I mean, it was beautiful. He did it, and I think that makes a lot of sense.